Thinking about all the scary health threats populating the airways? Wondering, is sickle cell the new cancer? Pause, think about it with intentional thought, and consider where we go from here. Stay tuned and hear what Dr. Wanda Whitten-Shurney got to say about what it is like to live with sickle cell disease and should we have hope for a full and ever recovery.
Something to think about with Dale Happy Knowles. What we think, we become. What we radiate, we attract. What we imagine, we surely can achieve. Let's change the narrative 242.
Welcome to Something to Think About with Dale Happy Knowles. Join our co-sponsors, DomDev Enterprises and Page Investments, and our friends from Something to Think About in this lovely discussion this evening on a subject that isn't talked about too often. And we have with us tonight the honorable, most gracious, most, I would say, hectic scheduled lady I know on this side of the earth. Welcome, Doc. How you doing?
I'm doing great, and I am so happy to be with you.
Yes, I'm glad that you could find two pennies of time to sit with us today and touch on a subject that I think we might have some of this in the Bahamas. I know we have a lot in the States, couple 100,000, I think, or thereabouts. And then, but we have all kind of different illnesses here, and we don't seem to drop down beneath the surface. A lot of the caretakers and what have you, we deal with what is common, but some of the specialty or the off the radar type activities we don't. And I think some of these things might be getting lost in the mix that could, if we diagnose them and be educated on what they are, can help people improve the whole situation.
Absolutely.
Right. Mm-hmm. So give us a little drop back of this 50,000 years of education that you have practiced.
Okay. All right. Mm-hmm. Well, let me start off with your title. Is sickle cell disease the new cancer? Absolutely not. And I don't want people to confuse it with any form of cancer. It is a chronic lifelong illness. I know people have said to me, well, sickle cell disease is the red blood cell disease and leukemia is the white blood cell disease. But of course, leukemia is a form of cancer and sickle cell disease is not. And people say things, one of the things I say, Happy, is that people don't know much about sickle cell and what they do know is wrong, and I have a lot of people that say to me, oh, I think the white blood cells are eating up the red blood cells and all kinds of stuff, all kinds of craziness, actually. And so I think the most important thing to know about sickle cell disease in terms of what it is that it's really a disease of the red blood cells. And that protein inside the red blood cells called hemoglobin is the problem. And there was just one amino acid in this protein that mutated from glutamic acid to valine, and that's what caused sickle cell disease to come about. Now, what it does is the protein, the hemoglobin inside the red blood cell, it lines up when the red blood cell does its job, which is to deliver oxygen to all the different parts of the body. And when that happens, the cells take on a sickle shape and a crescent shape, a banana shape, because a lot of people don't know what a sickle is, right? So a sickle is a tool that farmers use to cut weeds. So they named it after something that some people don't know what it is, right? And so I show a picture of a sickle and somebody will say, is that an ice pick or is that a hook? What is that? It's a sickle. So I also show a picture of the farmer using it so you can get a sense of what it's all about. But the problem with these red blood cells is they're fragile and they're sticky. And they stick to the wall of the blood vessel and they stick to each other and they from time to time cause blockage. And when you block the flow of oxygen, then you can't nourish your tissues. So you have tissue damage. And if you block the flow of oxygen to bone and muscle, then you have pain. So the hallmark of sickle cell disease is these unexpected, out of nowhere episodes of pain that sickle cell warriors, patients with sickle cell disease refer to themselves as warriors, and I think appropriately so. And they call this a pain crisis when it happens. And so that's the most common problem that you see in sickle cell. But then the other problem is because the red blood cells are fragile, they break down too rapidly. I mean, we're all making and breaking down red blood cells constantly, but the red blood cells that people with sickle cell disease have break down rapidly, and that's what causes the anemia. And the anemia causes people to be tired. And that's part of where that whole idea, another myth, is that people with sickle cell disease are lazy, but if you're running around with a hemoglobin of 6 when it's supposed to be 14, you're going to be tired, not lazy. So that's just, and we'll continue to dispel some myths throughout this conversation.
Right. Awesome. Well, Hippocrates, the father, who is considered to be the father of modern medicine, is credited as saying that healing is the matter of time, but it is sometimes also a matter of opportunity. Well, we know that we can't control time,
right?
But opportunities, we have the opportunity, or we have the ability to choose whether we will take the opportunity or not take it. And so when we look at that whole picture and knowing your background, academically, experience-wise, and exposure, you have had an abundance of opportunity of which to help people, of which you have. Your record speaks volumes to that. Everybody I call up and ask in the States about them, they know about what was happening in that arena, particularly from your father's point of view. And so, they don't expect anything different from you, which, this is a strange thing that we do in our diaspora, but, good thing about it is that you, to me, living up to the mark. Not that that's your intent, but, there's people out there who can try to grade you. My brother always talked about my father and his father, and how people always say he can live up to the mark. And so, we know what those pressures are, and we don't need those unnecessary pressures, because we got enough pressures in the world to deal with on the whole.
For sure.
But so, like I say, much love and respect for you on that. But can you ask me, why is it important to brace this opportunity to the first time around to address sickle cell the way you are doing it?
Yeah. I think that it's important because, sickle cell in the United States was first described in 1910 by James Herrick. And I think ever since then, we have definitively an underserved patient population. Right now, thousands of years ago, we know that in West Africa, they knew about sickle cell disease. They gave it names, and one of the names is bone chewing, the African, or the I don't know what language it is, but the term for bone chewing. So it's been around for a long time. But I think that if, people don't use Webster's dictionary anymore, right? But if you were to Google healthcare disparity, I really feel like a picture of a sickle cell warrior should come up next to a picture of a woman with cystic fibrosis. And of course, the sickle cell warrior would be Black, and the woman with cystic fibrosis would be white. And, I have the data to show the amount of federal funding that we get for sickle cell disease, the number of medications that we have for sickle cell disease. And I guess most importantly, the care that patients get, particularly in the emergency room. And what happens is when it's kind of like back in the 70s, people with sickle cell disease weren't living past 21. So adult doctors didn't really have the experience of taking care of someone with sickle cell disease. So now there are not that many docs that really are interested in it. If you are a hematologist oncologist, you can make more money taking care of cancer than you can taking care of sickle cell disease. Sickle cell disease is very complicated, both medically and psychosocially, because, of course, all of the parts of your body need oxygen. So if you had a problem with oxygen delivery, you're going to have a problem with all the parts of your body. So the coordination of the care between the seeing the lung specialist and seeing the kidney specialist and seeing the heart specialist, and then in addition to that, it's a psychosocially very complicated illness, because the mainstay for the treatment of pain is narcotics. Okay. And then we had this big opioid epidemic, and it seemed like they wanted to solve that epidemic on the backs of individuals living with sickle cell disease. So all of a sudden, it became even more difficult for them to get appropriate treatment for their pain. Now, my dad started what is now the Sickle Cell Disease Association of America. and it is now they're in Maryland. And when
Okay.
he did that, he felt like there were things that we knew about sickle cell disease that weren't being put to good use. And then
Mm-hmm.
when he started the comprehensive sickle cell clinic in Children's Hospital, he felt that kids with cancer were getting multidisciplinary care and kids with sickle cell disease weren't. And so he
Mm-hmm.
set up a clinic that gave wraparound services with full-time mental health professional, full-time social worker, me, the primary care doc in there taking care of the regular pediatric care, and
Mm-hmm.
then Dr. Ingrid Sarnak, the hematologist, taking care of the blood disease part, you
Right.
know? And so I just think that we need to pay much more attention and we need to get better care for these sickle cell warriors. Their average lifespan is 30 years shorter than the general population. And they are starting to live longer and longer, but what we need is for them to live better and better. So,
Yes. And so when we talk about that care, it's not just one, I don't know how to coin it properly, I would say disease, but it's a suite, right? Correct?
yes,
That is the
yes.
name. Yeah.
So sickle cell disease, there are three common types of sickle cell. SS, where you get a sickle gene from each parent. SC,
Mm-hmm.
when you get a sickle gene from one parent, and a C gene, which is another unusual hemoglobin from the other parent, and then sickle thalassemia. And then there's some other much less common types, but all of them together are sickle cell disease. The
Mm-hmm.
SS type is sickle cell anemia, and that's what people generally hear about is sickle cell anemia.
Okay. Yeah, and so when we look at people who have one of those, some of the symptoms they get, you mentioned pain already, but
Right.
what are some of the other symptoms?
Well,
Mm-hmm.
increased susceptibility to infection. So infection is a big problem. And
Right.
as I mentioned, it can affect every part of your body. So there can be problems with your eyes called retinopathy. There
Okay.
can be leg ulcers because of poor blood supply, particularly to the ankles. There can be a kind of pneumonia that we call acute chest syndrome. There can be painful swelling of the penis, which is called priapism. And
Mm-hmm.
then I think
Mm-hmm.
probably the most feared complication in sickle cell disease, once again, a disease of blocked blood vessels, a blocked
Mm-hmm.
blood vessel in the brain is a stroke, right?
Right.
So stroke can happen in sickle cell disease too. And I think that when I'm educating families about sickle cell disease, when I get to the part about stroke, that's really the scariest part for them.
Yeah. So I guess that makes a lot of sense to me, considering my walk, because as you know, in 2009, I had the battle with basic tongue cancer,
Mm-hmm.
and you mentioned that the blood cells being blocked, right, when
Right.
they're playing football, and
Mm-hmm.
there's a bunch of people because of the shape not allowing it to go through and
Right.
carrying the oxygen. So that's really and truly you suffocating yourself if you don't get enough oxygen
Right.
through your blood.
Yes.
But when I look at that, I sort of halfway wanted to equate it to my cancer experience when I was doing chemo, and I don't know if it's the same red or the white that went down to near
Mm-hmm.
nothing,
Mm-hmm.
but you felt very tired,
Yes.
like you didn't want to move. I didn't
Mm-hmm.
have pain, and
Mm-hmm.
thank God I didn't suffer from pain, but
Right.
I could imagine being tired and having pain, what that means to people, because you don't even feel like you have the strength to fight the pain. But
Mm-hmm.
um, no, I'm just trying to figure out
Yeah.
how it
Yeah.
is. And before you go, one person said that the pain that they experience is almost like if you mash your finger in the car door or door or the house, but that pain is being felt in all your joints and all these other spots where everything blocks up.
Right. Some people think that the pain is really indescribable.
Mm-hmm.
It's that severe. And I hear what you're saying about having cancer and the pain and the fatigue and all that. But uh, the thing about sickle cell disease is that it's a chronic lifelong disease. So you're
Right.
born with it and you live with it. And right now there's no universal cure for it. So, so you went through an episode of having great difficulty and then you were healed and now you're okay.
Mm-hmm.
And with sickle cell disease, it just never goes away, and so it's just always looming over you, when you get past the average lifespan or even, close to it, it's like, okay, well, am I going to die tomorrow?
Right.
And when you have a pain episode, I mean, I sometimes try to compare it to labor pain. right?
Mm-hmm.
And when I talk to women who have sickle cell disease that have a baby, they're like, oh, you call that pain? That is not pain, you know? And then the other thing is that when you have a baby and you have labor pain, you know,
Mm-hmm.
it goes away. And at the end
Right.
of that, you get a baby. You know,
Yeah.
at the end of a sickle cell pain
A joy.
crisis,
Yeah.
you just
Mm-hmm.
have the expectation that when is the next crisis coming and how bad is it going to be? And the
Mm-hmm.
other example is that patients in the hospital, sickle cell warriors that have had surgery, and you know, they give you that PCA pump, you know, patient controlled analgesia that you
Mm-hmm.
push the button to get your narcotics. And the nurses would come and say, how come you're not pushing the button? You know, and they're like,
Mm-hmm.
you think this is pain? You know, this is not
Mm-hmm.
even pain, you know, post
Mm-hmm.
operative
Mm-hmm.
pain. You know, sickle cell
Right.
pain is
Right.
something very different from that. So, yeah.
Yeah.
Mhm.
Cool. Well, that's very, very, very interesting. And the reason why I picked the title that I picked was basically for that same analogy that we just both went through, because um, cancer originally didn't have a cure, and then it had a cure. And
Right.
sickle cell, as I understood it, didn't have a cure or doesn't have a cure, but um, it's my hope, and I guess that a lot of people's hope that we'll soon have a cure.
Yeah.
Whether we get to that or not, I don't know. Really,
Yeah.
we
So,
all know that it's a disease that attacks. Um, a lot of people come from descendants from Africa more than any other place,
mhm,
kind of thing.
mhm. Yeah.
So you know, sometimes the powers to be don't want things to happen, but we'll see.
Yeah.
What would you say?
Yeah, well, a couple of things about that. One is that we do have a cure. Okay,
Okay.
it
Mm-hmm.
is bone marrow transplant because all of your cells come from your bone marrow, right? So
Mm-hmm.
if I
Mm-hmm.
take away your bone marrow and give you your sister's bone marrow, and your sister has sickle cell trait, then your body is going to act like you have sickle cell trait. Okay, so
Okay.
that's a stem cell transplant or a bone marrow transplant, right?
Mm-hmm.
But the problem is the bone marrow in a sickle cell warrior is full of cells because it's constantly trying to make red blood cells to make up for the ones that they're breaking down too rapidly. So we've got to get rid of at least some of that bone marrow in order to put the new bone marrow in. We have to clear the
Mm-hmm.
space. And we do that with chemotherapy, you know, and the medication
Mm-hmm.
that we use is busulfan. And that is number one, can cause you to be sterile. And number
Mm-hmm.
two, it can put you at risk for leukemia later on, right? And then the other thing about stem cell transplant is that, like, you know, if you get a kidney transplant, you can reject the kidney, right? But the
Mm-hmm.
kidney can't reject you. But if you get a stem cell transplant, you can reject it. That's graft rejection. So sometimes the transplant doesn't even work. But in
Mm-hmm.
addition to that, because the stem cells are the life of your immune system, the bone marrow can actually reject the patient, right? So the bone marrow
Mm-hmm.
gets in there and it's like, hey, whose body is this? I'm not supposed to be in here. And they fight to get out. And that's what
Right.
we call graft versus host disease. So it's no ride in the park, you know, to have
Mm-hmm.
a transplant. Now, in addition to that, there's some early trials looking at actually genetic modification, right? At actually fixing the gene, because it's
Mm-hmm.
just that one little pesky amino acid that mutated that caused it in the first place. So when I was in medical school at Howard University, we said, oh, because it's that single point mutation, we're going to cure this in 5 years, you know. Well, I graduated in 1983. Okay. I just
Mm-hmm.
came from my 40-year medical school reunion, and we're still in early clinical trials of actually, and what it is with the gene therapy is that we take the patient's own bone marrow and
Mm-hmm.
genetically modify it and then give
Mm-hmm.
it back to the patient. So with the stem cell transplant, you got the problem of finding a donor, right? But if we're
Right.
going to use the patient's own marrow, then we have the donor. So that makes that easy. And it's going to be his own marrow. So he's not going to recognize it as foreign. So he's not going to reject it. But the big problem is that we still have to empty out space in the marrow. So we
Right.
still have to use that chemotherapy with that can cause you to be sterile and can cause you to have a late effect of cancer, maybe 5 or 6 years down the road. So those, and I really think that that is probably the conversation that I have with families that's the most difficult. The decision
Mm-hmm.
about whether to pursue, you know, gene therapy or a stem cell transplant. And
Mm-hmm.
it's one thing for an adult to make a decision to take a life-threatening chance, you know. It's another thing for parents to sit down and try to make that decision for their child. That's
Children. Right.
a
Mm-hmm.
really, really difficult decision to make. And the other thing is that what we're doing to the patient's marrow is we're genetically modifying it, right? And we don't want to eat genetically modified food, right? And so, because of all the things that have happened to sickle cell warriors, they tend to be very skeptical, and they use that word guinea pig very often.
Right,
I don't want to be treated like a guinea pig. And so, I actually had a warrior come to the microphone at one of the conventions and say, am I going to grow a nose out of the back of my head if you mess around with my genes? And it's like, that's not too crazy. That's like, what's going to happen to me if you go in and screw around with my genes? So, that remains to be seen. We have to see. And when doctors really talk to patients particularly about the gene therapy, an honest answer to the question when they ask about long-term effects is, I don't know,
right.
and that's really what you have to tell people, because we don't know what it's going to be. Only time will tell. So that's kind of
See,
scary.
this is why I like shows like this and stuff, because when I started the show, I was under the impression that the only way somebody could get sickle cell is if both parents had the trait or the gene, or whatever the correct terminology you use for it.
Right. Okay.
But you mentioned that there's 3
Right.
methods
Right.
of it, right?
Yeah.
So how can we put the two with the parents? To me, being an engineer, I would say, oh well, just make it mandatory testing, and when both people have it, then it's a hard decision to make whether you're gonna be together or you're not gonna be together. But that seemed a little too simple. And I was saying, well, there got to be more to it. And now you say it's 2 other reasons. So how do you prevent those 2 reasons?
Yeah. So here's the thing. One of the missions of our organization is to see that individuals who are at risk for having a child with sickle cell disease can make an informed decision that they feel is in their best interest about having children.
Okay.
Because I have taken care of so many warriors that are not sorry that they were ever born. Right. And I was talking to a family the other day when the mother had said that she knew she had sickle cell trait. So she had her boyfriend tested for sickle cell trait. He didn't have sickle cell trait, but he had the C trait. Okay. So that was a sickle gene coming together with a C gene. And so now she has SC disease, and the mother was saying, if I had known that, I never would have had a baby with this man, right? And the thing is, then they have a beautiful young woman who is their daughter now, who has SC disease, who's doing well. And so what I said was, if your mom had jumped up and run away, then you never would have been born, And one of the things that we have now is newborn screening in every state in the United States. And so we're diagnosing babies at birth. And then the SCDAA in Michigan, we're the ones that call the parents and tell them that the child has sickle cell disease. And more times than not, Happy, the mother will say to me, that can't be, because I have sickle cell trait, but the father doesn't have sickle cell trait. And I'll say, well, how do you know? And she said, well, I asked him, or I asked his mother. And because it's a carrier state and it doesn't cause symptoms generally, instead of the guy saying, what is that? He just said, I don't have that, then you go through this whole thing. You can even get into a question of whether the mom cheated on because they can be really adamant that I don't have this, and then, okay, so that's not my baby. Okay, so that's a real problem. And then we bring him in and test him, and he does have sickle cell trait, or he has the C trait, or he has something called thalassemia trait. So if you get any of those 3 genes mixing with the sickle cell gene, if both parents have the trait, there's a 1 out of 4 chance with each pregnancy that the child will have sickle cell disease. And I had one mother tell me, well, I had one baby with sickle cell disease, so since it's 1 out of 4, that means I can have 3 more babies before I have another one. No. I have a family the mother has 3 children, and all 3 of the children have sickle cell disease. So every time you're rolling the dice, but that's how the genetics of sickle cell disease work.
Cool. And so I guess your synopsis is that there isn't a real way other than to get tested to understand who has what.
You have to have a special test to determine whether you have sickle cell trait or not.
Yeah, and not everybody could do the test.
Not everybody does the test. And sometimes they do the wrong test. And sometimes, they give misinformation.
Yeah. And you just hit it right on the spot. I was just going to ask, do people ever get misdiagnosed?
early on, people were commonly, I mean, they would go from doctor to doctor and they say, oh, you have rheumatoid arthritis, or a lot of the kids were told, oh, it's just growing pains, you know. So back in the 70s, that was a huge problem. But now with newborn screening that we've had in Michigan ever since 1987, then we are really clear on the diagnosis. And the other thing is that we're looking for sickle cell disease because there's a really important study that showed if you give young children penicillin twice a day, you can decrease their chances of dying from a very serious infection. So that's really how we were able to get newborn screening. But when you look for sickle cell disease, you also find sickle cell trait. And in Michigan, we have a very extensive trait follow-up program where we mail a letter to the mother and make a follow-up phone call to see if she got the letter, to see if she knew she had sickle cell trait, and to make sure that her child knows. And it's really funny because we're talking to a mother about her grandchildren, right? We want her child to know that when he or she grows up, if they have a baby with somebody with sickle cell trait, the C trait or thalassemia trait, they could have a baby with sickle cell. And we don't want you to do that by accident, only by choice. So it's an informed decision, knowing about the challenges that you might face.
So even though sickle cell is not, I guess, for across all ethnic groups, etc., there still is a lot of structure that y'all have been able to put in place for either treatment or post-op or post-diagnosis, etc. Is that across the country, or is that focused more in the Michigan area?
Well, it's focused in different areas, you know, and a lot in places where there's a high African American population, but there are places where there's literally not. And we know that if you get care in a comprehensive program, that you're definitively going to do better. And that's why I have this huge effort to start the Charles F. Whitten Center of Excellence at the Henry Ford Health System here in Michigan, because we have peds covered. You know, we've got, you know, a good program for kids, but, you know, when you transition, it's like a transition, it's a bridge to nowhere. You know, so we really need, and a lot of we see a peak in mortality at the time of transition. And a lot of our patients are getting care in the emergency room and in the inpatient setting. And that's another reason I think that docs don't want to take care of our patients, because the docs in the hospital are seeing patients when they're at their worst and when they're not getting good care. Right. And so you go in and you tell people they ask you, what's your pain on a scale of 1 to 10? It's like, well, that's not high enough. How about 1,000? That's where my pain is. And then they look at them and they've had pain all of their lives. And if they're not screaming and hollering and crying, then they don't believe that they're having pain. And then they do their blood pressure and their heart rate. And they say, oh, your blood pressure is not elevated. Your heart rate's not elevated. You couldn't possibly be having pain. These folks have had pain their entire lives and they've dealt with it, right? And then the worst thing that they do is say, well, let me draw some blood. And then they come back and they'll see that they're anemic, you know, but if their counts are pretty normal for them, they say, oh, all your blood work is normal. So, you know, but there is no blood test that picks up pain, you know, and so having people wait to have some blood work done before you can get relief from your pain is totally crazy. But that happens constantly in sickle cell disease. It's a huge problem.
And on that, I heard that they and doing some research where you have they're looking at some markers. I don't know whether it's out of the blood or something else that would be able to tell.
Yes, and I am really excited about that. Yep. And one of the people that's working on that is Dr. Patrick Hines, right here in the Motor City in Tech Town. Okay. You know, and Dr. Hines really feels as though pain is an unacceptable endpoint for sickle cell warriors. And that if you have a high cholesterol, we don't wait for you to have a stroke. You know, if you have diabetes, we don't wait for you to go into diabetic ketoacidosis. We give you metformin, we give you insulin. So he has identified in a study called the Ellipsis study, has identified actual biomarkers that can predict that a sickle cell warrior will have a pain episode within the next week with 50% accuracy. Wow. So if we could bring those patients in, right, to the clinic when we see that their markers are high, What could we do? We could hydrate them. We could address their stress, because most sickle cell pain comes out of nowhere. But we know that stress is a key factor that can precipitate a pain crisis. Maybe we could give them some anti-inflammatory medication, because we know that a crisis has a lot to do with inflammation, and we can use things like meditation and things to just kind of maybe help prevent the pain episode in the first place. So that's really exciting. And then in addition to that, he has synthetic blood vessels, and he can take a drop of the patient's blood and run it through a synthetic blood vessel and measure stickiness and measure fragility. And then he can treat the blood with the medication and run it through again. So we have a medication that's good for adhesion, and we have a medication that's good for fragility. So instead of having to experiment, so to speak, on guinea pig the patients, we can just look at their blood and see what might be the best medication for them to be on. So I really feel that we really may be changing how we take care of sickle cell warriors based on all of the science that that people are learning about.
Yeah, science. Science. I always say science is God's gift to man to help us understand his principles and his system of relationship. Somehow we seem to think it's one or the other, but I think they go hand in hand. But so now when we look at that whole introduction of the science itself, so maybe some. And by the way, folks, you out there, you are welcome to ask your questions and comments in the chat. And I'll endeavor. Madam Producer is not with me tonight, but we'll endeavor to get them all posted so the good doctor can answer what she can and for what she can. We straight up. We don't flam people around here. So, where was I? So if we look at these items now, and we say that, how should I ask this? Yeah, if in the United States you have the challenge, but you conquering it one step at a time, and the United States is what we call the mighty United States in this region. Now we look at the developing countries in the region, and I guess maybe across the world, going as far up to Africa, where I guess most of the issues you mentioned would have been in early medicine, where they would have called it something different. How big of a gap do you think it is, if you don't know, between, from your experience and talking with people, what might be happening out here versus in your big city, your big country?
Yeah. So let me start off by saying, that people always think about sickle cell disease as being a Black disease, and it is a Black disease, and that causes us a tremendous amount of difficulty, right? But the thing is, it's not just a Black disease. And you see sickle cell disease wherever you see malaria, because if you get one sickle gene and you have sickle cell trait, that protects you from malaria. So you're more likely to live and to reproduce. But then if you reproduce with somebody else that has that same gene, then you have a baby with sickle cell disease. Now, if you have sickle cell disease, you're still less likely to get malaria, but you're more likely to die from it if you do get it, right? And so you would think that you would see sickle cell disease wherever you see malaria. Now, we don't have malaria in the United States. And they're seeing a few cases in Florida now with that COVID denying governor down there. But you don't really see it in the United States. So you might ask, well, why do you see it in the Bahamas? Why do you see it in the United States? And that is because of the transatlantic slave trade. So when they brought us over here to build this country for free and then tried to act like they were teaching us life skills and they were doing us a big favor, we brought our sickle cell genes with us, and I just think about, the possibility of our ancestors, because I really believe that we're standing on the shoulders of our ancestors who survived that. I don't know how I would have, but I just think about even those that might have been on that ship and having a sickle cell pain crisis during the months-long journey, to come to this place to be treated the way they were treated. But in terms of thinking about under-resourced countries, There are some places where the average lifespan for people with sickle cell disease is 5, because there is not good treatment. And also there's this concept of the obanji, and that's a baby that comes to the family that's not really supposed to be there because it has an evil spirit, and it's actually supposed to die and go away. And there's
Okay.
some places where they believe that sometimes sickle cell babies are obanjis, and so
Mm.
they're not supposed to live. So the gods are going to send them, a baby with a better spirit. In addition to that, in some places, it's really like shameful to have a child with sickle cell disease, and that people don't, they don't want to know, they don't want anybody to know that they have sickle cell disease. And that's something that I found even in the United States, that a lot of times sickle cell warriors don't want to share the fact that they have sickle cell disease, even young children, even with their best friends, at first I thought it was because of shame, but in
Mm-hmm.
talking to people, it's really because they don't want to be treated differently. They don't want people to feel
Mm.
sorry for them, so they don't want people to know. But yes, it's a much bigger problem there. We have roughly 100,000 people in the United States, but Nigeria, the incidence of sickle cell trait in Nigeria is 1 out of 4. It's 1 out of 12 in the United States for the trait. But because
Okay.
malaria is endemic in Nigeria, then there you
Right.
still have that driving force, so that you have a lot of people with sickle cell trait, and therefore a lot of people with sickle cell disease. But I think that the movement to try to do things globally has been really making progress, and medications like hydroxyurea that for 20 years, we only had one disease modifying medication. That was hydroxyurea. But the problem was it's a repurposed cancer drug. It was initially
Mm-hmm.
used to treat cancer, and people don't want to take it. They're like, I don't have cancer. I'm not going to put that toxin in my body, and it's back to that kind of being skeptical, being thought about like a guinea pig. But in places in West Africa, they welcomed the medication because there weren't other things to do, so there
Right.
was a
Right.
much better, so there are all kinds of programs in terms of trying to do more research and actually train scientists there to do sickle cell research and to get better treatment in under-resourced countries.
Well, is some of those toxins and those poisons and stuff like that. Brother Dylan always said that. Yeah, they poison you half to death, and then they finish burning you up the second half of your death. So that's why you're still here, because
Yeah.
you didn't kill the whole death.
Right. Yeah.
Cool.
Mhm.
Yeah. So when we look at this sickle cell disease suite of items and what we have here, um, where does sickle cell stand on the chart of fear? So, when people hear the big C, cancer, everybody start shuddering, and maybe if you're in a crime zone and murder is an issue,
Right.
or you have pressure issues, hypertension, Alzheimer's, and diabetes. Where is there a space so people could understand, if people who knew about it, where should they put this particular disease?
That is a really good question. And when you talk about fear, I can
Mm-hmm.
talk about calling a mother and telling her her child has sickle cell disease. So she's
Mm-hmm.
got this, we call when the baby's about 2 weeks old. So she's got this nice, juicy baby with 10 fingers and 10 toes, looking all healthy.
Mm-hmm.
And then Dr.
Excuse me.
Whitten-Shurney, who are you? How did you get my phone number? What? No, my baby doesn't have click,
Right.
and
Mm-hmm.
and so, but then you get the mothers who it's more of a sadness, when they
Wow.
find out about the diagnosis, and they go through a grieving process, and I think sometimes it's very, very similar to Elizabeth Kubler-Ross's stages of death and dying, and
Okay.
the first stage is denial. So in the meantime,
Mm-hmm.
I'm trying to share the diagnosis with them, and I'm trying to get the baby on penicillin, but they're in denial that this couldn't possibly be true. And then when I tell them we have to
Right.
do a confirmatory test, they say, "Oh, you got to do another test." Oh, that is probably not true.
True.
So there
Right.
are all
Mm-hmm.
kinds of things like that. But when you talk about fear, when you talk about am I scared to have another baby because my first baby had sickle cell disease? And one of the things that I see a lot of young mothers, and one of the things I say to them is that, are you ready to have another baby right now? And
Mm-hmm.
almost uniformly say, no, I'm not. And then I say, are you having unprotected sex? And they say, oh, yes, absolutely. And so it's just like, wait a minute, those two things don't go together. And can you stop
Yeah.
by the drugstore on the way home and pick up some condoms and some foam and then go to your OB or whatever? Because we want people to make informed decisions about having children. So I don't think that in most cases, it's so scary that you wouldn't take the chance of having it happen again. And so but I think when you have the disease, it's very scary. And when you're raising a child that has the disease, it's very scary, because you just don't know. It's so unpredictable. And another thing that's really important about sickle cell disease is this thing called phenotypic heterogeneity. And what that means is that every patient is different, you know? So, and I call my patients snowflakes because every snowflake is different, right?
Okay.
And so then while you're trying to teach people about this disease, you also have to let them know, because I start education with the family when the baby's like 2 months old, and I tell them everything, because that's when I have a captive audience. It's like we do a video conference and we talk about it. And it's scary. It's scary. So I really want to emphasize how no one child is going to have all the symptoms. And we can't predict. There's some kids that do really, really well, and there's some kids that are very, very sick. And the day that we make the diagnosis, we don't know which category your child is going to fit into. Now, that's an area of research to try to figure out who are going to be the sicker kids so we can use more invasive treatments on the kids that are going to be sicker. But I really emphasize how you really have to take one day at a time and deal with issues if and when they arise. Because if you just keep in the forefront, oh my God, my child's going to have pain. Oh my God, my child's going to have a stroke. Then you're going to be crazy and the child's going to be crazy. And I have some families who I really feel like the fact that the child was overprotected was a bigger problem for the child than the sickle cell disease, and then, kids are smart and they know how to push their parents' buttons. And if they know that their parents are worried about pain, it's like, oh, well, if you have to wash the dishes, oh no, my hands hurt from my sickle cell, I can't wash it, and so kids do that, not because they're bad kids, because they're smart kids, so
Adults do that.
Exactly. Right. So, so there are just so many factors that, come into that. And one of the things I really think about too is the brothers and sisters of sickle cell warriors, because I think actually sometimes, I know sometimes the siblings are actually jealous of the child that has sickle cell disease because they're getting all this attention, so that's a problem. Or sometimes they have survival guilt, it's like, oh, well, that happened to my brother, but it didn't happen to me, so there's so many issues. And it affects, sickle cell disease affects the entire family. Sickle cell disease affects the entire community,
Right. And so on that point, then, going through treatment, how does that affect well, we know the patient just want relief, but how does it affect children patients that you deal with a lot with, and being pediatric, and also, like you said, the siblings and parents?
Yeah. So the treatments, initially, particularly, one of the things that I say all the time is that kids with sickle cell disease aren't sick all the time. They're sick from time to time, and it's very important that the parents not treat them like they're sick when they're not sick, and it's almost important to not treat them like they're sick when they are sick, because there's that secondary gain. You go to the hospital, get all these cards and balloons and, special treatment and so forth. But, in terms of treatment, when I first started, all we really had was pain medication, antibiotics, and blood transfusions. Now in 2007, well, in the 1990s, we got hydroxyurea. But again, only about 20% of the people in the United States that would benefit from it will take it because they're scared of the side effects, or they might get cancer, or they don't have cancer, they don't want to take chemotherapy. But then in 2017, we got something called Endari, and that really stops the oxidation, which is a problem in sickle cell disease. And it's actually L-glutamine. So it's an amino acid. It's a naturally occurring amino acid. And so people are much more comfortable taking that than, the chemotherapeutic agent. And then in 2019, November, we call that the November to Remember, because within a week, we got 2 new medications. One was Adecvio that deals with the stickiness, and the other is Oxbryta that deals with the fragility of the red blood cells. So now we have lots of treatments, and and that's another thing about this cure, this genetic cure or the bone marrow transplant, is that with HIV/AIDS, we don't have a cure, but we have really good treatment, and people can live a long, productive life. So if we can get kids started on disease-modifying therapies early, then maybe we don't really need the genetic cure. And I don't want to fight against science, and I know people want to take that chance, and I believe they should have the opportunity to do that. But one of the concerns that I hear about that is that if you're an older person and you go through the genetic cure and your body has been through this wear and tear all of this time, then you've got heart problems, you got liver problems, you got kidney problems, and gene therapy doesn't fix any of those. And warriors feel like a cure should make you whole. So they even challenge the use of the word cure to describe gene therapy. And then in addition to that, if we do that, women who have sickle cell disease, all of their eggs carry the gene for sickle hemoglobin, and men have it. All of their sperm carry the gene for sickle hemoglobin, and that it doesn't fix that. So it would seem that a genetic cure would fix your genes, and so it doesn't. So there's still, just a lot of issues and controversy about, what's the best thing to do.
Yeah. So
I don't know if I even answered your question, but I said a whole lot.
It answered a lot of other things too, so that helps.
All right, good.
Yeah. So when we look at this whole picture, though, and we talk about what it does, you call off a lot of medicines. I hope that plane didn't cut in, but you call a lot of medicines, and I know that medicines is not a cheap thing.
Right.
I recall, and I might be off in terms of the duration, but the MD Anderson Moonshot Project, where they started to say they wanted to eradicate cancer. That was something, if I remember right, was something like $4 billion a year for so many years, or it might have been over so many years, $4 billion. I can't remember what it was, but it was a huge amount of money for talking about in the 90s and stuff when they started. Does these type of things happen for some of the diseases like sickle cell and the right? Do people fund corporate funding for this?
In the United States, when I mentioned that Googling sickle cell versus cystic fibrosis, even today, there's many more millions of dollars spent on cystic fibrosis research than on sickle cell. Now, things are getting a little bit better. And my dad actually worked with Roland B. Scott and President Nixon to do the Sickle Cell Disease Control Act that actually got some funding. And then the NIH had some centers that were funded to do sickle cell research. We lost the funding for those, but now there are a number of actually pieces of legislation that are on the table now, to fund comprehensive sickle cell clinics around the country so that we can make sure that everybody's getting multidisciplinary care. And just even specific to Michigan, our governor gave the SCDAA over $5 million to help start the adult program in the Henry Ford Health System. So things are not where they need to be, but they're getting better. And yes, absolutely, the high cost of medication is very difficult. There are a couple of drug companies that had clinical trials for the genetic cure for sickle cell disease, but they decided that it wasn't economically feasible. They weren't going to make any money, so they ended the trials for that reason, because they weren't going to make money. So, if you ever want to know why something happened, if you just answer money, then that's probably the correct answer. And then the other way that money impacts that whole situation is that hydroxyurea has been around so long, it's generic now and it's inexpensive. And so here in Michigan, for Medicaid patients, and that's another big part of our problem, is that we have a high Medicaid population, and Medicaid pays low and slow. And so doctors don't want to, they want to make money. So you get, sickle cell warriors aren't the ones to make money off of. And so when we got some of these new medications, they wanted people to fail hydroxyurea before they could get one of the newer medications. And, and it's just because of money, but here's the thing, if you can't get the warrior to take hydroxyurea in the first place, how are they going to fail it in order to try to get the new medication? So that's one thing that we really fought against, and that's step therapy. So we don't have step therapy for the medications in Michigan, but they can come with high copays, and there's some copay assistance programs and things, but it's still, the cost is still very difficult.
Yeah. So shifting gears a little bit now. So knowing your schedule, that I don't know when you breathe, but and also your experiences that you've been having and stuff like that, to become a champion in this space. If you wanted to duplicate that in the Bahamas and the rest of the Caribbean, etc., how do you go about that? What does a person need to have within them to make them have the passion and drive that your father and yourselves and the rest of the team is having?
I think that's a really difficult question for me to answer. I know that a lot of, because I have sickle cell trait, but my father didn't even know that. So everybody wants to know, is there somebody in your family that has sickle cell disease? And in fact, just as a little side note, my father walked into the kitchen one day and he said to my mother, I think Ethel had sickle cell disease, and Aunt Ethel was my godmother, right? And Aunt Ethel was little and skinny and had yellow jaundice and would miss school. And my mom would say, Ethel, why do you miss school so much? And she'd say, I don't know, Eloise, it's because I'm anemic, and she died from a stroke. And so then my father said, I think she had sickle cell, but that, of course, he didn't know at the time. That's not what inspired him. I think what inspired him was the fact that there was this disease that was affecting Black people, and that we weren't using the information that we had to make things better. And then, of course, as growing up, and people say, you're going to be a doctor like your father. I'm like, oh no, I'm not going to be a doctor. That's out of the question. I'm majoring in math, and I'm going to be in computer science. And happy to tell you the truth, I woke up one day at the University of Michigan, and all of a sudden I had a bunch of science classes, and the next thing I knew, I was in medical school. And then I finished medical school, and my first rotation in the clinics was internal medicine. There were a bunch of old people, and they were sick, and I can't do this. And so then my next rotation was psychiatry, and it's like, oh God, no, I can't do this. And then my next rotation was pediatrics. I said, oh, okay, I can do this, And so I did my pediatric residency. And I said, oh, being a general pediatrician, runny noses and ear infections and diaper rash. No, don't think so. I think that maybe cancer and blood diseases, and I had really good mentors in that area. So I did a year of a hematology and oncology fellowship. I went to 9 funerals in a year, and I spoke at 3 of them. And there's something you're supposed to learn called detached concern. And I never learned it. I was attached to all of my patients. And I walked into the chair of hematology and said, Dr. Lusher, I'm just really not cut out to do this. And my last rotation was in the comprehensive sickle cell clinic that my father started. And it's like, I'm home. This is where I want to be. Right. So 30 years hence, I'm back to going to funerals, but instead of a patient that had a tumor in their kidney that I took care of for 6 months and they died, it's a kid that basically I helped raise. From the time they were born, I told the mother that the child had sickle cell disease, and then took care of them until they turned 18. And now in my work at the SCDAA, I'm still in touch and running a support group and all that kind of stuff. So it's just, and I think that for me, the passion and the motivation, of course, some of it came from wanting to continue my father's legacy. Part of it came from wanting to have a legacy of my own. Right. And part of it came from being around sickle cell warriors who were getting good care, and knowing how just wonderful it was to take care of these families, because they're just so caring and so nurturing, and, helping kids through hospitalizations, and now adults when they're being mistreated, and you make a phone call and then things maybe turn around for the family, that kind of thing. I think that's kind of really what keeps me going. I see my warriors getting married. And, I have one that is in medical school now. And she's
Mm-hmm.
really in medical school because of another program that my father started, the post-baccalaureate program that helped Black students get into medical school. She's at Wayne State University. So I feel like, and then when you go to medical school, there's this white coat ceremony. So I took care of
Mm-hmm.
her. And then she asked me to coat her at her white coat ceremony. So I felt
Okay.
like my
Mm-hmm.
dad helped her get into medical school, helped her with sickle cell, and I took care of her, and then I coated her. So, it's stuff like that. It's stories
Mm-hmm.
like that. People that come up to me and say, Dr. Shurney, I don't know. I know when you told me about the diagnosis that we were going to make it, and I had to really push my child, and I did that. And now they're in college, and I'm just so thankful to you that you were able to help us get through this journey. So that's I think that so in terms of in the Bahamas, we've got to start in medical school, to get
Mm-hmm.
people interested in sickle cell disease. By the time they're in the clinics and doing residency, it's really too late. And, there's not much taught about sickle cell disease in medical school now. And then on clinical rounds, doctors even describe patients as drugs. Oh, they're just in the hospital to get narcotics. They actually say that on rounds. So
What?
that's what residents are learning,
Mm-hmm.
and so it's just, I think that if you could get exposure to patients that are getting good care, then you would think that, this is really something that's wonderful. It's a fascinating disease, and providing really good care is very rewarding, I would say.
Yeah, they say that success is contagious, but I also say so is not being successful too, right? And so people could go in both directions.
Right.
But you obviously were in an environment that had a lot of positive success, and so that helped, and maybe that be the answer. But when we look at this whole picture, then so I look at
I'm
the
happy. I'm
Bahamas
going to
and
plug in my computer because I didn't have it
this
plugged in.
dying. Hmm.
It's gonna die if I don't plug it in right now. So hold on, I'm gonna look here, and
Yeah,
now I am plugged in. Okay, we're good to go.
yeah, yeah. So I always say that the places like the Bahamas and the like is where we should be finding the cures
Hmm.
for different things. Whether it's all these trees, the old people with bushes, as we call it. We go and get this and get that and rub this together and fix this up and steam it up and whatever and boom, boom, bam, person healed. But I mean, obviously, you need a little bit more than just that.
Right.
But when we look at that whole picture of it, um, so what would it be beneficial if a place like a Bahamas became the Eden for, say, sickle cell or other ailments, where people could come here? Does the environment create a better chance of recovery or,
Yes.
or
Yeah.
healing?
Yes, absolutely. I've had some warriors that have moved to places like Arizona, because of the weather, Texas, and they seem to
Okay.
do better there. Just if you're just talking about the weather, and
Mm-hmm.
also if you're just talking about bright sunshine, and living basically in paradise, I think
Okay. Mm-hmm.
that's it. And getting in that salt water, I think is got to be healing and kind of curative, right? And then there's some of those out islands that I want to get to, family islands that have that healing water too, But in Jamaica, there's a very famous doctor, Graham Sargent, that took care of a lot of patients with sickle cell disease. And one of the things in hotter weather, one of the downfalls is that there's a higher chance of getting leg ulcers. And so I think he became an expert in taking care of leg ulcers. But
Mm-hmm.
yes, I do believe, and what I find that and probably Michigan is one of the worst places because when warriors get sick is not so much when it's hot or when it's cold, but when the weather is changing. That's when we
Mm-hmm.
see patients coming into the hospital. So yes, I think that if the Bahamas could be a place where you could go and get care for your sickle cell disease, I think it would be really wonderful. You have the same migration from the slave trade that brought sickle cell disease to the Bahamas, right? And
Mm-hmm.
that, yeah, that would be fantastic.
Cool. Well, I have to give my sister Danielle, who actually gave a couple of shout outs in the show earlier.
Okay.
Where put give that give 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 that to her as a project to
Okay.
to coordinate, and
All
then we
right.
could get all the relevant technology, and I could find those people, and then you could find the experts. She find whatever she finds.
And there
She's a
are
put
people
together
who
person. You know where she
are
go. Yeah.
there
Mm-hmm.
are people that are ready to do training, because
Yeah.
like Dr. Ohani Frempong from Ghana, he had a son that died at 40 from complications of sickle cell, and he was the chief of hematology and oncology at Children's Hospital of Philadelphia. And he would travel to Ghana. He started a newborn screening in Ghana, and he taught people how to take care of patients with sickle cell disease. So that would be something that would be really positive, to have a major center of excellence for sickle cell disease in Nassau. There is a center of excellence for sickle cell disease in Tanzania, led by Dr. Julie Makani. And that's when I tried to go to the governor's task force around this whole
Mm-hmm.
issue of healthcare disparity. I said, there's a center of excellence in Tanzania, and there's not one in Detroit, so let's put it together, right? So
Yeah.
yeah,
Mm-hmm.
I think that would be really great. Mhm.
Cool. 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 Well, Doc, I've asked you a lot of questions, and
Mhm.
hopefully they were relevant and provide value to the listeners and persons out there, and they were able to be able to position themselves better to to seek the treatments and be more confident in their
And to know
ways
whether
of
they have
thinking.
sickle cell trait before they have a baby, so that they
Oh
can
yeah,
make
yeah,
an
yeah, yeah,
informed decision about having a baby.
yeah.
Mhm.
So,
Yeah.
but I was gonna ask you. See, I asked you a lot of questions. I always ask my guests: is there something that I might have missed, or just don't know that you would like to say to the public out there
Hmm.
that help encourage them or give them
Hmm.
some information that might be pertinent?
I'm thinking about all of my kind of like elevator speech. And I think that you kind of hit most of the really important things.
Okay,
I
awesome.
think that, there's a lot to do with now implicit bias, right? And implicit bias training, and, trying to figure out, how to get people to treat Black patients better, right?
Mm-hmm.
And my thought about that is that there are some people that are just racist and
Mm-hmm.
white supremacists, and
Right.
they think of us as being subhuman. And I really truly feel that the only way to this is racism is learned, right? You learn
Right.
it
Right.
from
Mm-hmm.
your parents. You don't come here, you're not born a white supremacist or racist, right? So for me, the solution to racism is to go into the homes of families who are racist and take the kids out and put them in foster care in families that aren't racist, right? Because
Wow. Mm-hmm.
otherwise they're just going to be taught that. I don't know how to undo that. And so I'm
Right.
not really all that interested in all this implicit bias training. I don't really care how the doctor feels about that particular patient, whether they think they're subhuman or not. What I care about is the quality of care that they have to give to that patient. So I really feel, and there are protocols, and that we have to have a way of seeing that patients get the right care, irrespective of how the doctor feels about the patient. Because I think for the most part, you're not going to change how the doctor feels about the patient. So that
Right.
is one thing that I think is really important. So the American Society of Hematology came up with these trifold, nice little brochures about how to care for sickle cell patients. And so then they distributed them to doctors. But
Mm-hmm.
I said, you don't know what doctor's going to see what patient, so let's distribute them to the patients.
Right.
And
Mm-hmm.
so, and then, so it's that way, because I hear warriors that come in and say, Dr. Shurney, I sat down with the doctor and he looked me straight in the face and said, I don't know what to do for you. And then,
Mm-hmm.
hey, here, doc, here's what you do for me. Look at this. There's one on hydroxyurea, there's one on blood transfusion, there's one on routine maintenance care. This is how you take
Mm-hmm.
care of a sickle cell patient. And when I initially got involved in a grant that had to do with increasing the number of docs that would take care of patients, and I found out how difficult it was to get people interested in taking care of patients, I said, well, let's figure out if there's a way that we can help patients to take better care of themselves. And I
Right.
put together what I call a patient empowerment toolkit. And it has a blanket, because emergency rooms are cold, and it has a thermometer because a fever is an emergency in someone with sickle cell disease. And it has a pill sorter to help them remember what days to take, their medications on.
Right.
And it has a really important tool called an incentive spirometer, which I call a lung exerciser. Because when
Yeah.
you're in the hospital and you're having a lot of pain, you don't take good deep breaths, especially if you're having chest pain, and then narcotics suppress your respirations. So I always tell folks it's 10 times a day. When you're having pain, you've got to keep your lungs open so you don't get pneumonia or acute chest syndrome. But the other thing that's in that toolkit is a passport to health, where we need sickle cell warriors to be activated and informed and ready to participate in client-centered, patient-centered care. So, don't come telling me you take some little blue pill. The only blue pill that I know is Viagra, right? So I don't tell me the color of the pill that your child takes, tell
Right.
me what minute. So I want you to write down your whole history. When did you get your gallbladder removed? When did you have your first pain episode? When was your last blood transfusion? Do you have antibodies from blood transfusions? So that when we send these patients from the pediatric side to the adult side, then they
Right.
can give a really good history. And the doctor's like, oh, look at who I have to work with, as opposed to
Right. Right.
somebody saying, oh, I take a blue pill and I think that I might have had a transfusion in such and such, just to really know what's going on. And actually, doctors really need to understand that patients know their bodies and they need to be believed. They know what works for them.
Right.
If a warrior goes to the emergency room and says, I need so many milligrams of Dilaudid, at this interval and whatever, it's because they know and that's what works for them. And that's what gets them labeled as being drug seeking. Oh, you
Right.
just want narcotics. No, I want pain relief. I don't
Right.
want
Right.
narcotics. And that if I could get it without that, that's what I would do. So, I think that's a really important point. And I think the other thing is that this whole scale of 1 to 10 pain stuff, rate the
Yeah.
pain on a scale of 1 to 10. I had a family one time where the doctor came in and woke the patient up and asked her what was her pain score. And she said, it's a 10. And he said, well, it couldn't possibly be a 10 because you're asleep. And she said, well, I can sleep during pain. And so, but what I asked the patient was, is there a level of pain at which you wouldn't be able to sleep? And she said, yes.
Right.
And I said, in the doctor's mind, that's a 10, so you probably in his mind were at a 9. So what we really need to do is really describe pain in a more functional way rather than
Right.
giving it a number. I have pain so bad I can't sleep. I have pain so bad that I can't sit still. I have pain that, it's really bad, but because I've experienced it for so long and I'm using my meditation and deep breathing, that I can sit here still and talk to you, but that doesn't mean it doesn't hurt. And then the other thing is that people think like they have to say that they're at a pain at a 10 in order to get any attention at all, because if you
Right.
just say that you're at a 7, then, oh, who cares? So it's just, there are just so many things that need to happen that need to be different, so that's what we're working on.
Well,
Mm-hmm.
that's great because I know when I was in the hospital, well, being treated, I was always on the other end of the spectrum saying how much how more zero can you be, right? And
Mm-hmm.
they none of them believe me. The doctors, the nurse, RN nurses, mom, all the people say you can't be zero, you can't be zero, and everybody's
Mm-hmm.
thinking about what the other patient's experience was, and
Right.
so they say you
Right.
can't be zero, you can't be zero. But I'm like, well, this don't make any sense to me anyway because it's just numbers on a page. There's
Mm-hmm.
no discussion to say what the numbers mean before
Right.
you
Right.
give a
Right.
reading. So
Mhm.
what one mean to me might not be one to you. So,
Exactly. Yeah.
and that's why I was encouraged when I heard that, with the markers and stuff that is going on, that there
Mhm.
might be a way that you could actually either forecast the pain or read the pain itself,
Right.
levels
Exactly.
itself,
That
and so
is
forth. So that's
really
great.
exciting research. I'm really looking forward to the day when pain is absolutely an unacceptable endpoint for people living with sickle cell disease.
Right.
Mhm.
Awesome. Well, Doc, kindly, thank you kindly for taking this time out. I think this is a lot of information and people around the Caribbean and even in Dubai and Canada. Sometimes we get people from Ghana
Good.
and stuff listening on. Hopefully there'll be value to them and they can take it and run with it and share it wherever you want. But do hit like until that button's break, right? Because that's how the information gets to your friends and other people when you're not doing it. YouTube and Facebook will share it for you and so forth. Madam Medusa, wherever you are, continue to do well. Hurry back because
Okay.
this
I'll look forward to that.
And we will also welcome you back at the earliest opportunity that is pertinent to you when you have some new and big stuff you want to say, like you opened that great center you was talking about.
Okay, that'll be great.
Awesome.
Thanks, cuz.
You're welcome. Do well.
Okay.
So everybody out there on social media, do. Please, be safe. Learn as much as you can learn. Take care of your body. And we'll see you next week.
Enjoyed the show? Then subscribe to us for more educational and inspirational content. Ring the bell so you never miss a show. Let's change the narrative 242